site. I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the first people and the traditional owners and custodians of the lands and waterways on which we live. We honour and pay our respects to elders past and present. We recognise all Aboriginal and Torres Strait Islander people and their ongoing strength and resilience despite the past and present impacts of colonisation and dispossession. And so, welcome to you all. Now, Carolyn Mockabell, who has a standing association with this meeting, to give a bit of a snapshot of the current landscape. Carolyn from 1-800 My Options, are you available to give us a bit of an update?
I am. Thanks so much, Patty, and thanks everyone for having me. We've been, I know I keep on saying this every time, but we've been really busy at 1-800 My Options. We had a record month in August. It was around 80% above our regular August figures. So I think that that's reflective of the fact that there are certain parts of the system that are struggling a little bit to meet local needs. And that particularly applies to the surgical system from what we've seen. Now, I've had a look at our data for this time this year compared to last year to see if we're seeing any of the trends that we had appearing through COVID changing at all. I can say that generally no. So we're still seeing high numbers of people over 18 weeks looking for abortion care. I think that this comes out of the fact that, you know, there are times when people are obstructed from accessing care, whether that's by pregnancy partner, family, or sometimes, unfortunately, by health professionals. But it's also just the fact that some of the waits for certain things, such as ultrasound, etc., are still taking a bit of time. We still speak to people who are waiting for a couple of weeks for an ultrasound, which is very frustrating for everyone involved. And it's really great to hear that there are a few more GPs and others either getting their own ultrasound or developing relationships with ultrasound providers so that we can fast track that a little bit better. We're also seeing, we've seen a little bit of a drop in people talking about having financial insecurity, but it's not particularly significant. So this time last year, it was around 35% and we're down to about 32%. So it has dropped a little bit, but it's still about a third of our callers are talking about having financial access as a significant barrier to receiving the sexual and reproductive health care that they're looking for. And we're still seeing, we're starting to see a little bit of an increase in international students presenting to 1-800 My Options. That makes complete sense. Obviously, we've opened the borders again. We've got more international students arriving. But again, the issues that international students face when they're accessing sexual and reproductive health services are quite significant. Obviously, without Medicare, everything costs a lot more. With new international students arriving, it means that there are more of them who don't have coverage in their insurance for pregnancy-related care. So it can be incredibly cost prohibitive for them to access an abortion, often over $1,000 from start to finish, which makes access for them really, really quite difficult. But I think that those are the key things that we're seeing change. They're not unexpected, obviously. I think we all could have expected some of those things to be happening. But we're looking really closely at the data that we've got and trying to work quite closely with a number of providers to maintain and increase access. And particularly as we get more international students coming through, I'm expecting more tourists and also more people on working visas as well. Those numbers to start increasing again, we'll be looking at different pathways that we can use for them to be able to access care, particularly in the first 9 weeks or so. Thanks so much, folks.
Thanks, Caroline. It's interesting, international students are coming back on the scene. It's sort of an indicator that things are sort of getting back to normal.
Overall numbers, Carolyn, from this month's steady state or continuing to go up?
This month it's a little down from what we were at last month. So last month we were averaging somewhere between 30, 35 calls a day. This month we're down to about 25. Last month was extraordinary though. So this month we're already about 15% above the numbers for our average September. So we keep on trending to increase numbers of calls all year, if that's been the case.
Are there any questions for Carolyn about 1-800 in general or her presentation this evening? Okay, well, look, without further ado, I want to introduce our two speakers, and I think Alex from Geelong will start with you. So we've got two of our clinical champions, one from Geelong and the other Natasha. Welcome, Natasha, from Ballarat. We're going to talk about their recent endeavours, successful, to expand access to abortion care in their regions. So you have the floor, Alex.
Thanks, Patty and Kath. And I guess also a big shout out to Anne Hotchin, who is on the line, who's one of the other gynecologists at Geelong, who's been overseeing the Choices Clinic down at Barwon for many years, and also Grace Blythe, who is one of our GP registrars involved in the Choices Clinic. So I guess just as a brief overview, we currently have a service which includes a weekly clinic in which there's also a sexual health nurse for contraception counselling and a social worker if women choose to see them. And we see 8 patients for surgical determination, in which the doctor consents them, and we'll do an ultrasound if needed for gestation. And then we have a weekly surgical list that they go on. And we currently have a gestational limit of 12 weeks. However, now to extend this to 16 weeks. And I guess that's what I wanted to really discuss tonight in this forum, as to anyone else's experience in terms of how they've moved towards that model. Currently, between 14 and 16 weeks, we're really caring for patients in kind of an ad hoc way, because the service capacity depends on which gynecologist is available. And that's really not ideal at the moment. And also regarding ultrasound, we ask for that prior with the referral, just to help us triage, I guess, by gestation. And so Patty and Kathy asked, I guess what are the problems that we're seeking to address? And so our main one is really, we see the regional demand for up to 16 weeks gestation for the Western region of Victoria. So we currently, all of our providers, we've got 8 surgical providers in our department, and we are all comfortable up to 14 weeks, but we're now looking to extend that really up to 16 weeks. And we currently have quite a mixed skill set. And we also have a new fetal medicine unit, which has really just opened in the last 2 months. And we're now becoming more aware that if women are going to be given real choice as to whether they have a medical or a surgical termination at that 14 to 16 week gestation, this is kind of an opportunity for our Choices Clinic to work together with our fetal medicine unit to be able to give women these options. We'd also, I guess the other issue that we're trying to address is that we'd really like to focus on training both of our O&G registrars and also GP registrars. But at the moment, accredited RANZCOG trainees are not allocated to the surgical list, pretty much because of staff shortages, and we don't have real fund, like the funding model seems complicated to have a GP registrar paid to be at those surgical lists as well. So that's one issue that we're really hoping to address. We just haven't really been able to work that out. And we'd also like to secure funding for our nurse role. So our current model is really quite dependent on a lot of goodwill from particular dedicated individuals, both in nursing and in social work admin, who really go above and beyond their actual prescribed roles to be able to provide an excellent service. But we'd really love to be able to sort of consolidate that and make it sustainable and acknowledge the work that they do and be funded appropriately for that. if anyone's got any thoughts on how we can present that to our department, because I guess in the next sort of element, I guess that Patty had asked me to speak on was our process for advocating for change. And we're really very lucky in that we have a supportive head of department and we have a supportive executive of our hospital. And so we also have good consensus amongst the group of surgical providers. And I think amongst us all, we all would like to work towards being able to provide a 16-week service. But it's often around how we structure the model, how we're going to fund it moving forward. So I guess the other point that you asked me to speak on was on our supports and enablers and barriers and challenges. And I guess big shout out to you ladies, Patty and Kath, and also Carolyn for your tireless support of a regional service and really backing us up in our goal to extend to 16 weeks with upskilling. And I guess our other greatest asset is that we've got really committed providers, and we've got an excellent specialist nurse practitioner attached to our unit who we borrow from a sexual health service, but she's about to go on long service leave. And so, who replaces her? Does anyone replace her? And it just shows that there's kind of instability in the system by that not being an actual well-defined role. The other element, which I think is because I also oversee our early service, so the EPAS unit, which are really trying to publicise that we're very supportive of GPs in the community providing MTOP, and so that we can support them in managing complications or providing surgical, just be able to provide them support in managing retained products, either through medical or surgical management. And yeah, I mentioned our fetal med unit that's just in the process of being set up. So I see that as an opportunity to expand. Yeah, and I guess so possibilities for future development. There's the extension of our service, but whether that will also, at the moment, our surgical service really just meets our current demand. Whereas if we now are bringing in women to a later gestation, and if that means from more of the regional area, that may increase our numbers. So whether we need to look at additional clinics, additional theatre lists, but it does seem like there is that capacity there that we could, I guess, put our hand up for within the service. And I'd also be interested in people's thoughts on us developing an MTOP service, which we don't currently have. At the moment, we've really been sort of working towards supporting GPs providing this in the community, but whether within what we've been talking about is particularly if we can attract GP registrars or other O&G registrars who are interested in sexual health to be doing a weekly MTOP clinic in which they also provide LARC. And I'd just be interested in people's thoughts on that, whether that should be a hospital service. I mean, it means that we can provide women with a comprehensive service, but are we then undermining the local primary care efforts? But it also could open us up to being a training site, possibly for the advanced training module for RANSCOG in the future, because we'd love to be able to support training regional providers, both in the GP stream and in the O&G stream. I think that's pretty much from us. Have I left anything else out, Anne? Or Grace?
No, that's all pretty comprehensive. Thanks, Alex.
Alex, if I could just make a comment and ask a question. So the comment is that I really don't think that you, by providing MTOP, would in any way be competing with local providers. We run a small MTOP service here, and obviously the songbook that we're all singing from is that MTOP can be provided outside of tertiary and secondary hospitals. And that's a great model, but you do also have to train those residents and registrars coming through, and also train them in an awareness of how to deal with post-procedural events or presentations. No, I don't call them complications. They're presentations with someone who's concerned about the amount of bleeding they have. And we know from our experience at the Women's that initially when MTOP started to happen in the community, we were doing an awful lot of needless curettes for incomplete medical abortions, which we now realize are a process, like a miscarriage is a process. And so it's actually part of the training, Alex. And I think I really like that idea of yours of, excuse me, I've got a frog in my throat, that idea of yours of having the LARC clinic and the MTOP clinic, because it becomes like a comprehensive MTOP clinical service. And would you be thinking of having that on yet another day? Is that what you're thinking? So
no, we'll be thinking of having, like, ideally we have the abortion clinic in the morning, like the surgical abortion clinic in the morning, and then in the afternoon having the MTOP and LARC clinic. Because
when
then
the
it could
theatre
be,
list is running.
the theatre list is on a different day the following week. But it would just mean that if we had, for example, a GP registrar, they could be there for the whole day, and that's well supervised and supported. And then you've also got your nurse and your social worker there as well.
And great. I think it's worth working on. And I see your GP trainee Grace, isn't it? Nodding her head on the screen. So obviously she approves. The question was just
all approve.
What was that, Grace?
Yes, all approve. I think Alex knows how I feel, but it's hard. I think there's probably a lot of other GPs here tonight as well, but GPs and providing MTOPs in the community is, there's definitely providers that can definitely be done, but there is a bit of mixed kind of, I don't know, say feelings about providing them, just because it requires kind of like a long consult. The GPs don't get all that well remunerated. Some of them feel like they can be doing, essentially more work for maybe better money in less time type thing. So it is kind of a bit difficult. Also as well, like I am always very kind of pro access type thing. MTOPs in the community can be a bit expensive for women as well, because if they're paying for a few visits, they're paying for kind of a long consult, they get a bit back on Medicare, then they pay for another one, then they pay for the medication. So, certainly a public hospital service where they're not paying for those visits is definitely a good thing.
The more options, the better. And of
course, definitely.
We are also working with the hubs to provide bulk build services. So the sexual and reproductive health hubs. Now that you're getting questions, which is really good, Alex, that's a sign of a good presentation. So Danielle Mazza has got her hand up, and then Catherine Orr. So we go to Danielle first.
Oh, thanks, and thanks, Alex, for your work and in promoting abortion services through this area. I'm very interested. It seems to me like just hearing you talk that it's really like a business development kind of issue, because the issues that you're talking about are around staffing and financing, and you say you've got a supportive executive and a supportive management within the hospital. But I wonder if they could assist you by providing some expertise around the kind of modelling that's required around the staffing and the resourcing. Because I think GP registrars would flock to you, in fact, if they knew of the availability of this kind of training. And the model there is around the GPs registrars filling those resident positions, and how more can be put on by the hospital. So it just seems to me that it's really a business kind of modelling exercise that's required.
Yes, and like I have no insights there at all, Danielle. So because we've wondered about that, and we think it would be a great training role for a GP registrar. Because I think Grace, who's one of our GP registrars, she, in terms of so I don't know about the complexity of how that all fits together, but for example, like for her to attend our lists, she was attending them just in her own time to keep her skills up. And we would love to be training her, but it's just that then the hospital says that there's no money to pay those hours. So
Is Is Grace doing a DipObs position?
I've done my advanced DipObs. I've done it.
So what kind of role do you have in the hospital, Grace, then?
So I'm an ex-gynae reg. So I kind of regged for a few years in the hospital at a few different hospitals with kind of Alex and Anne, and made the decision to transition kind of away from O&G and towards GP to kind of pursue some other interests and some life balance. So I've kind of been able to remain connected. It's a little bit tricky because I'm doing GP training full time. So it's just negotiating hours and things like that. But I do the Choices Clinic just once a month, and it's really kind of almost through my established relationships that I've been able to do that, and I certainly do get paid for it at the moment.
Yeah. If I could
Whether
just
or not we could set up a relationship with the GP training that we get
Yeah.
that actually paid for in some way, it's tricky. I mean,
it's a matter of resident. It's a matter of the hospital having allocated spots in their residency program for usually diploma in obstetrics and gynae for GPs to select into, and if the hospital advertises this as one where you can get this kind of training with MTOP and with LARC emphasis, then I'm sure that you would attract. So it's really a business model issue where the hospital has to negotiate the residency positions, and it involves the colleges, the GP training program, and the colleges. And I think, Paddy, this is a kind of issue that needs to be talked about in the college with Judith Gardner to get her involved and supporting these kinds of issues.
We'll move to Catherine Orner, and then I think it was Anne Hodgson who may have some insight into the training of GPs in Geelong. So, Catherine, fire away.
Hi, Alex. I thought that was really great. I just wanted to give a perspective and sort of reinforce what Danielle has said, that there's a lot of GPs interested in providing abortion, but there's no pathway, which we've talked about a lot. But the idea, if you could do a special skills or advanced rural skills or whatever the college calls it, as a 6-month rotation to do LARC, MTOP and STOP, and also manage the complications without having to do, because I don't want to do a DipObs. I don't want to be on call in hospitals and deliver babies, but I would really love to have that focused LARC and STOP skills to add to my list. So I think it would be a really attractive post. And I mean, Danielle's talked about how you could fund it and maybe try and fit it into a GP training. But I don't think you're stepping on anyone's toes, and I think it would be fabulous.
Anne, you had your hand up before. Is it still up, or?
I think I wrote something in the chat. We did actually have, that's why I bet about the MCCC. We did have a resident, an HM, I think she was an HMO 2 or 3, I can't remember where she was, PGY 3, I think, who did do a 6-month post with us, aimed at basically becoming an abortion provider, both medical and surgical. And we struggled so much to get the MCCC to, I don't quite understand that. I don't quite understand how the system works, so I'm sorry if I get it wrong, but to actually say that it was an adequate post, that the hours she was doing in the attending clinics, because she did it as part of she didn't work with us full time. She did it as part of her general practice training, and she did something like 13 or 14 hours a fortnight doing a Choices Clinic, a list, and then an MTOP clinic, which we used to run at Barwon Health, but that fell apart because of lack of continued junior support, etc. So yeah, I think there's a long ways to go. And I think the part of the problem is, Catherine, that like her, others don't want to do the full O&G resident job. And so therefore we need a kind of parallel process that is really, really linked to primary care.
Yeah, I guess I could chip in from the college point of view, that through the special interest group in reproductive and sexual health that I'm involved in, we have recently had approval of our advanced training 2-year course for registrars in O&G who want to do an alternative pathway and really become sexual and reproductive healthcare specialists. So at level 5 and 6, they peel off and they do this 2-year training, which is really a copy of the British College. And we're just about to run our first 2-year program starting in February. So that took us 6 years to get there. And we announced this at our recent conference, and we immediately got the response that we're getting from Danielle and yourselves and Catherine. What about the GPs? You know, we need a pathway for them. And look, we have heard this message well and truly, and that is the next agenda item, to work out, as Anne says, a pathway where you don't have to do the full diploma of ONG or the advanced diploma of ONG, but you can become a sexual and reproductive health special interest GP. And our college writes the curriculum for it. And I think once the curriculum's there, then the positions might follow. It certainly gives you leverage to develop the positions. So I think this is like a multi-front attack that we need to have. And I was really overwhelmed with the interest from general practitioners, both trained and in training at both of the conferences that I went to recently. So I think the moment is now for us to both run our first advanced training one and then look at an alternative one for GPs. I'm just aware of the time, and so Alex, you've kind of raised lots of food for thought. I think if we could move to Natasha, and each area's got their own particular strengths and challenges. So Natasha, tell us what's happening up in the Grampians region.
Thanks, Patty. Thanks, Catherine. Can you guys hear me? Yeah. It's interesting because I was grateful to meet Alex and Grace and Anne at the conference recently and share stories. And I think what's happening in the Grampians is we're sort of taking a different path. We're probably trying to end up at the same place. But what we've done here is we currently have a reasonably good medical termination service, and that's quite robust. We don't often need to refuse people due to lack of spots. However, we were finding surgical termination access really difficult because we were trying to fit the surgical termination into the general gynae lists, and because of the time critical nature, it was very, very difficult. So we have had some success. We've been campaigning for a dedicated surgical termination list, and we have been given a dedicated surgical termination list at Ballarat Hospital, which is great. So thanks. So it's starting. So there are a few caveats, which I'm sure we're going to overcome. And I feel a bit like, you know, we've planned this day, you know, swimming almost or something, and we've got our rashie and we've got our sun cream and everything, but we're not sure when we're going to reapply sun cream or whether we're going to do any of that. We're not sure how it's going to go, but we're jumping in the water. So the caveats are that we need to audit it, which we would have done anyway, that the list can only be used for surgical termination of pregnancy. It can't be used for miscarriage or other gynae cases. If there is leftover time on the list, then it can be used for a cesarean, or otherwise it goes to the general emergency in the hospital. Then also the other caveats is it's a 6-month trial. So if we if it's determined, and different people have different opinions on how much the list is needed, I personally think that the list will be needed and will show that we will need those lists. If not, we ask for one list a week. So I think potentially we might even go towards that. But if it shows that there's not enough women needing a surgical termination in the Grampians after the 6 months, then it may be stopped, the list. In terms of staffing, interesting also the contrast with the Barwon area is that we've been asked to staff it with a registrar or GP registrar. And so in the first instance, we're staffing it with a GP. We started staffing it with Laura, who's been great actually as part of our service for the choices and providing a lot of women with termination over the years. And Laura is going to do the surgery in the first month and then first few months, and then we are trying to transition to a GP obstetrician role with training. And then the other success we've had, so we've had a few successes, because after this conference, one of the messages at the conference was equity of access, and also what can you do? And that was a sort of a light switch change for us, because I think we'd been looking so long at all the perceived barriers, but actually there's always more that we can do. And so some of the things in the Grampians that we'd come back and try to change was there is a high rate of gatekeeper problem in the Grampians. And so we did look at self-referral. That was one of the things we came back to look at. And our nursing staff were really worried about the impact for them, because at the moment the gynae nurses are doing it as an unfunded part of their job. It was never costed into their job, and they did an audit 17 hours work a week for them. So they're worried if we became self-referring that they would have an increase in work. And so what we've done with that is we've asked for a reproductive healthcare clinical nurse specialist for the Grampians region, which is in process but hasn't been approved. So that's been in movement. And then the other success was we've used our private practice fund to purchase an ultrasound machine for our clinic. So that means women don't need an ultrasound. And if they don't have one, we can do it in the clinic, and follow-up will be a lot easier. So that's been a great success. And the other change that we made was we reviewed our rhesus guidelines after the conference, because we found out we were giving too much rhesus anti-D. So we've reviewed that, and up to 10 weeks we're not giving anti-D. Then what else? Oh, we also got an extra medical termination clinic. So we've actually got this medical termination once a week clinic, and it looks like it's quite busy because it's about 16 patients a week, which is quite hard. And so we've asked for an extra clinic, which was just approved. So that's been great. That's going to start in November. So we've had this scattergun approach, and a few of the things have succeeded all at once. And so, yeah, in terms of the surgical list, that's starting the 5th of October. It's a fortnightly list. It does require a GP referral, and we've decided to go to 12+6. I'm not sure what other people do or feel about that. We thought with our current training, we could go to 12+6 at the time of surgery and be confident that we're doing a good job. And we want to have a safe service and an equitable service. The other thing that's helped, I think, is the amalgamation. So Grampians has amalgamated 4 hospitals, and we're now Grampians Health: Ballarat, Eden Hope, Stawell and Horsham. And so that's first of all changed a lot of people in the hospital. Like, it's changed a lot of people's roles, and it's created this new focus for everyone. And they did consumer feedback and staff feedback, and they came up with a motto, which is equity of healthcare access for all, which is great because it's so online with what we're trying to do. And so I've proudly got that on my email signature now if I need to email anyone. Yeah, so I feel like things are moving in the right direction. Thank you. Be interested to hear anyone's thoughts.
Oh, that's fantastic, Natasha. And if I could just let everybody know about, like, very rapidly, it wasn't that long ago, we were up visiting Ballarat and teaching a GP to do LARC insertion, and visited your clinic and saw and had the clinical meeting with your leads and saw the reticence. And there seems to have been a few dominoes fallen over for you, which is fantastic. I think that that concept of having a regional sexual and reproductive health nursing specialist is really, really innovative, because that's one of the things about the Grampians is it's a huge referring area, isn't it? Is there anything that we can do about messaging to make sure these lists are full from the get-go for you guys? Because we know the demand is there, but one of the things that had happened in the past was it was so hard to get through for patients through the gatekeeping that the list, in fact, it appeared to some of your seniors that there wasn't really much of a demand. Is there anything from SERSH or from the network point of view you would like us to do? We certainly will be in touch with all of the people that we know refer, and I'm sure you will be, but is there anything in addition you'd like us to do?
No, I'm not sure. I've contacted 1-800 My Options, and that's been, I believe, updated. Yeah. And we've contacted our GP liaison in the hospital to send out a message, and they said they have sent that out to the GPs that they have the contact details for. I'm not sure if there's any other. Do you know of any other avenues for GP communication?
What about the PHN?
Yeah.
GP
Okay.
liaison be onto that, I imagine. But yeah, could make sure that place is covered.
Yeah. Okay.
Because they do a regular newsletter or whatever whatever their channel is to GPs.
And we can certainly talk to the advocacy partners and the practice nurses and the nurse practitioners that talk to us regularly from the Grampians area. Just thinking of, the people we know in the network. Some of them aren't there tonight. So we'll make sure that everybody knows about that. And what's your referral process? Is it a phone number, and are you allowing self-referral?
No. So the idea for the nurse came from the nursing staff, the gynae nursing staff, that innovative idea. And yeah, when they told me about it, it just clicked. Like, that's exactly what the Grampians need. There's such a wide area. And I'll just think about a woman who, doesn't have transport, who's vulnerable in Horsham, who needs a surgical termination because she's past 10 weeks, or, it's exactly what we need. We need this reproductive healthcare nurse that has a mobile phone that you ring and you get triaged. Yeah. And ideally, we ultimately want to have lists even installed to improve access, because now we're all one hospital, one service. So that's something on the horizon if this goes well. Sorry, I can't remember your original question.
So currently, if you think of anything we can do, let us know and we'll contact all of our contacts. B, at the moment, what's the current referral pathway? Is it via the GP still?
It's still via the GPs.
Okay.
So when Laura and I came back from the conference, that was what we thought could be a quick win.
Yeah,
is changing that. But there was a concern from the gynae nurses, and I really want to support them because they've actually done so much in this space, and they do a great job. So that we have 2 gynae nurses who run all of gynae, basically all of gynae outpatients, and they hold a gynae referral phone. And then I asked them to do an audit of their work on this space, and they said the termination of pregnancy space does take up 17 hours a week.
Right, it does.
On average. It's not like an average phone call.
No, yeah.
Yeah.
So is your hope then, Natasha, if you get this position, then their patients could self-refer?
Yeah, so they want EFT. The gynae nurses very reasonably want EFT to be able to do self-referring.
Yeah.
So in contrast to Bowen, we don't have a social work on our clinic, social worker, and we don't have any nursing EFT. I'm not sure if Bowen does, but we don't have allocated nursing EFT, which would be a big help.
Yeah.
So, but in Grampians, like if we were going to design an ideal service, we would certainly have self-referral because of the gap. Yeah.
I'm just noting this down because that might be something that we could campaign together on, Natasha, to get the EFT for this. I'm calling them the super nurse, but you know what I mean?
Yeah.
The nurse all over the Grampians. Yeah, that would be fantastic. And maybe it could be from your hospital, but also external in our bid to the government directly. So
I mean, yeah, they could work from home. It could be a job share.
Yeah.
I thought, it could be a really popular job because there's a lot of autonomy. It could involve GP education and sort of GP support.
Yeah.
And they could potentially upskill, they could skill to do cycle smears, long-acting contraception. Like it could be like a reproductive healthcare And we thought, yeah, so we thought it's got could be quite an attractive role.
It could be a bit of a win-win for the government who talk the talk about wanting to develop advanced nursing practice too, you know? Yeah, so let's keep talking about that. Are there any other questions from, I'm sure there are, from the rest of the team? Alex Bonner.
My question, just Natasha, was, and I've already put up my hand where I was thinking, the sexual health nurse sounds amazing. How are you going to fund it? And because I think, you know, as clinicians, we don't really know how to navigate the systems to work out how do we get funding for these things. And we just seem to just go around in circles and we talk about it amongst ourselves. But it's about how it just seems very hard in the hospital system that seems so stretched to get an allocation of funding, particularly like I know you're the director of a department, so you've got some degree of, but, you know, then to bring in nursing and to get nursing FTE, any insights would be, I mean, every regional hospital could do with a sexual nurse practitioner, and that would get all the services moving, because I feel like, you know, and gynecologists, we just get so slowed down by the logistics and the admin. Like the procedures themselves are so straightforward, but it's all the systems that we need help with.
Thanks, Alex. Yeah, it's a really good question. And I do feel some responsibility with my role that I need to use it to advocate for what we need. But it is really different when you're trying to get nursing EFT. It's a whole new world. For me, just personally. So what I find is, well, not that we've had success yet. So I find, first of all, actually deciding on what you want and putting a plan in is probably 50% of the battle, because often people, if you have a conversation with them, like you have a great idea and then you have a conversation with someone who you think could approve it or not, and you feel like they don't really like the idea. And so then you never put the plan in, and then it's never going to get approved. But if you, regardless of your first feedback, so yeah, my technique at the moment is you make your plan, get feedback from people who are going to give you good feedback, as in useful feedback, front of line feedback on whether it's going to be useful or not. Then you decide whether the plan's what you need or not. And then if it's exactly what you need as a unit, then you put the plan in regardless of initial feedback. Of course, have those initial conversations just so everyone knows you're about to put the plan in. You need to talk to finance. I personally need to talk to the finance department, whoever's affected. So for the stop list, I had to talk to anaesthetics, theatre nursing, and then my own department, and then the gynae nursing staff and the GP staff. And then you put the plan in, and then as my experience has been, at some point it will be approved if it's a great plan. So what's happened with the stop list is we've put this in, and then at some point there's been a change in leadership, or something's happened with the funding. It's hard to really understand. And then you suddenly get a notice that it's been approved. And so it seems like, I reckon 50% of it's actually deciding what to do and putting it in. And then if it gets rejected initially, because we've had that experience as well, every 3 months, just re-asking, where is this at? What does it need for approval? Why is it not approved? And then they'll give you the answer, whatever the reason is, because there's not enough admin staff, because this, and then you go and try and hunt down that person. So it's a slow process, but if it's a great plan, I think eventually it does get approved. But Rosie, I don't know if you have any comments on this. You might have some other ideas that work better than mine.
We already have increased our nursing FTE in the clinic a lot, and so our nurses work across all of the guys.
Patty,
yes.
I just wonder, I know who you are, darling, but could you tell everybody else where you're from? Because it's very important everybody knows where you're from.
I'm Rosie Buchanan. I'm the clinical director of ONG at Warrnambool, Southwest Healthcare Warrnambool. And we've got a public gynae clinic with an MTOP service that is partly run by myself and the registrars, and partly run by GP obstetricians who've already done DIP-OBS. We employ a lot of them to help with antenatal clinic and with the on-call roster. And so we've just basically moved them sideways into the sexual health clinic. And we also run a surgical termination service up to 12 weeks gestation, but we just use our own lists for that. We're not big enough, I think, to have a dedicated termination list, at least not at this stage. But in terms of nursing FTE, we have gynae nurses who work in the clinic all the time. And so they just work across all areas, basically. The FTE about the GPs is probably the thing that I have to add, which is that they did dip-obs with us. We kept them on their contracts and we use them on the on-call roster, but we can also use them in clinic for that reason. So, yeah. We also have a social worker for all of the abortion patients.
That's great, Rosie. How long has your MTOP service been going?
Well, I've been full-time up at the public now for 5 years, so all of that time. And I think Michael Koutsoukas was doing it before me as well. Yeah.
Well, that's great. So it's really, quite well established. Siobhan Burke has requested.
Hello. I was just going to say a couple of things because I work in one of the sexual and reproductive health hubs, is that the nurse role there could be a good example of what a sexual and reproductive nurse could do in a hospital instead of the hub. And because the funding will come from state government, then that might be a model that you could superimpose onto yours, Natasha. And then the other thing I was going to say is that within that role, there's quite extensive roles in there. One of them is around the GP education, etc. And we find that our nurse is so busy with clinical things that she never gets to that role. And so I'd think really carefully about how much you put into that nursing role, that the super nurse might become the drained, overworked, not getting to some of the things, frustrated nurse.
Any other questions for either Alex or Natasha? I think what I would like to just reflect on is that this has just been a wonderful example tonight, hasn't it, Kath, of how this network can work to share ideas and share, gains and get a little bit of insight from Sphere, and then get a bit of insight from another clinician who's got a different model, and asking GP registrars what they think. This is what this completely democratic online forum is all about. And I really want to thank you both for your presentations tonight, really thought-provoking, and have given me a couple of ideas for our next round of funding fisticuffs with the department. It's now just coming up 10 to 7, and usually at this part of the meeting, we invite any of the other participants from around the regions to share anything new.
Anita Moss was there before.
She's here. Yeah, I'm just staring at Anita Moss because she's got something new to share. So this is our opportunity for anyone to say anything or ask a question. Could I just put you on the spot, Anita Moss, and you could tell us what happened last week?
Thank you, Patty. So nice to see so many faces that I met at the conference too. And great presentations, Alex and Natasha. And it's really great to see you guys kicking some goals in this space, regional areas. So I'm from the Mornington Peninsula. I'm a GP obs. I work at Peninsula Health, but I've just opened my own private service in Frankston. The Peninsula Health MTOP clinic does 4 MTOPs a week, and it's staffed by a GP obstetrician, Dr. Nikki Martin, and Kathy Halmarick, who's a nurse prac, and 2 sexual health nurses. So Peninsula Health doesn't have a stop list at the moment. So most of the cases needing surgical termination tend to go to Hampton Park from down around here, or otherwise Murray Stopes and fertility control. My little service is just, I'm a one-man show with 3 amazing sexual health nurses, one of whom is here, Robin Holmes, who moonlights from Peninsula Health as well. And we're offering nurse-led STI screening, contraceptive counselling. I'm doing MTOPs with their support in counselling. I have bought a little ultrasound machine, so it's nice to be able to offer that service as a one-stop shop. And we have pharmacy on site I mean, nestled, I'm sort of hidden in a corridor in a big super clinic, a bulk billing super clinic, and the executive who of that corporate clinic, or the GP recruiter actually who took me on board, fought for me at executive level to have this service there, because there was concern among staff about, will there be protesters and, you know, all that sort of stuff. So we're the start of week 7. We're quiet, but we're happy, and we're streamlining our processes, and we've got support with Peninsula Health EPAS because I work there as well. So I've had a few cases who are too early, so off they go to EPAS, or, you know, patient presented with a misplaced IUD. So we managed to get her into Peninsula Health for hysteroscopy and whatnot to remove it. So that's what I'm doing down on the Mornington Peninsula.
Well done.
Yeah. Fantastic. And it was a great evening that some of us managed to get down to for your launch. Anyone else want to tell us anything from their area? I just noticed in the chat that Dale, Queensland Health has a nurse navigator. They've got nurse navigator roles. Some are TOP nurse navigators and some are sexual reproductive health nurse navigators. And there's a link, and we'll take that link and see if we can, you know, perhaps work on a model for that, for funding for here. So thank you for that, Dale.
Patty, can I just do an advertisement around a Sphere webinar we're running October the 6th. If people don't know, we're running a webinar. I'm going to be talking about, the topic is integrating medical abortion into primary care, learnings from the Churchill Fellowship. And I'm going to be talking about the international experiences and how things are run overseas. If people are interested, you just have to register through Eventbrite.
The date again, Danielle?
October the 6th. It's going to be a lunchtime webinar.
Okay.
Do you want to put the link up, Danielle? And
I would, except I'm making meatballs and
I wonder what you were doing.
I'm multitasking.
I'm sorry, this is a vegan format here. Okay, if you want to send it to myself and or Kath, we'll promulgate that for you.
It's on the Sphere website too.
Okay.
Thanks, Carolyn. There it is.
Carolyn Mockabell from 1-800, has done it for us. So it's there. She's clearly not making meatballs. Great. Any other comments or questions?
I have one.
Oh, yeah, Anita. Yeah.
I have one question, Patty, around the sort of merging of GPs and hospital services. Could someone, Carolyn or anyone else, talk to around the PHN and your experience with PHNs responding? Because the Southeast PHN, we've tried to contact them. We cannot get in touch with them, even to say we're here, but we don't, then no one answers the phone, no one answers the emails. And in the newsletters we receive that are coming to my inbox, there doesn't seem to be a lot of details about sexual and reproductive health. Thank goodness for WISE, because we're hearing more about goings on in local area through them. But what's happening in the other PHNs, does anybody know?
So Anne's put something in the chat. She said, I think what she means is that the PHNs are interested in chronic disease, but what she's written, I absolutely love. It's got PHN equals chronic disease. So,
that was
so
completely Freudian. I'm sorry.
I would say I'm a board member of the Southeast Melbourne PHN, Anita. So I will take your.
Oh, great, Danielle.
Yeah, I'll take your concerns back to the CEO. The issue is, I think that they would be reluctant to advertise private services because they would say that everybody would then need a private service. So I think the issue is how, if you want to let people know about your service, it's how to do that in a way that doesn't seem to be pitching privately.
We certainly have noticed that PHN groups are really variable.
Yeah.
Some are very like Anita. I mean, they don't even actually know, Danielle, that Anita's private because she hasn't had a chance to get anyone to answer the phone. So we've had the same problems, and I think Carolyn said something similar. There are some PHNs that are working really, really well and others that aren't. So it'd be useful for you to let us know which PHNs are see this as an issue. Others see it as something they really don't want to get involved in. Anne.
Just a bit of feedback on our interaction with West Vic PHN. We did the health pathways with them, and I think that's one way of getting into the GPs, the knowledge of what's going on around the place, where you can send your, patients who have urinary incontinence, need an abortion, et cetera, et cetera. So that's one way we got around it. And potentially, given every GP is supposed to be a private practitioner, I think that, that's sort of a little bit of a typical government way of avoiding their work that they're supposed to do. But the other thing, this is completely unrelated, it's just because I've got a bunch of people who are in the space here about lobbying. We've been struggling a bit with getting people to be MS two-step providers, or at least signing up to get access to mifepristone, because of concerns regarding people who aren't MS two-step providers and aren't keen not to be linked with abortion, but still have to obviously work in the field of mifepristone for other things to do with gynecology, including medical management of miscarriage. Does anyone have any bright ideas on how to lobby the TGA potentially, and what changing the restriction on access to mifepristone?
Yeah, and lobbying the TGA, that's a really important thing. And I think there's quite a lot of, and Danielle might say something about it too, there's a lot of different groups trying to bring that about. It's quite complex, and it's complicated by the fact that we have a monopoly provider for MS two-step in Australia, and every jurisdiction around the world is different. With regard to having difficulty getting other ONGs to provide mifepristone, I imagine you're thinking about management of FDIU or management of medical management of miscarriage. That's off-label use, and they don't have to be an MS two-step provider. Thumbs up, they really don't. They run it at the Mercy for medical management of miscarriage, and I think that's proof positive that you don't need to be an MS two-step prescriber. So that's one good thing. Did you have something to say, Danielle, about the TGA and lobbying?
So the TGA has formed a women's health products advisory group. I sit on that group, as does others with an interest in abortion care, and it's on the agenda of the TGA committee. Murray Stopes has been invited to speak to that committee, and I've been briefing Jed Carney and also Robin Langham, who's now the Chief Medical Advisor to the TGA. She was previously Professor of Rural Health at Monash. I've given her a briefing about it too. There's a lot of interest from the TGA in terms of promoting the evidence around mifepristone and easing the regulations, but it's a matter of Murray Stopes actually putting forward an application to do so, and they are taking some steps in that direction, and trying to address things like the product information and take out inconsistencies. There is going to be some issue around trying to increase the gestational limit because that might require more misoprostol, and at the moment the package is set for MS2 step. So there is quite a lot of activity happening in this space, and a good deal of willingness, I think, by government and TGA to actually take steps in that direction.
Well, that's been a great update from you, Danielle, and again, witness to the fact that this is a really live and helpful forum for providers across Victoria. So thank you everyone who contributed tonight. Do we have a date, Kath, for our next meeting? Kath Lacheret.
Oh, sorry, I haven't checked the next date. It's in November, I think it is.
We're just checking.
Can Sarav help me out? No, it's the 29th.
It's the Tuesday, the 29th of November, everyone. Put that in your diaries, but we will send out a reminder. I think we promised to have some very interesting presentations at the next one as well. So thank you very much for your attendance. Go well, everybody. Keep
well done.
Keep up the good work.
Yeah, thanks, Alex and Natasha.
Bye for now.
Thank you. Bye.
Thanks. Yeah, I'm going to catch you tomorrow.
Oh, good.
Yeah. Is Rosie still there?
Yeah.
No, sure. Is Rosie's one of those ones?
Because it'd be good to hear how Rosie gets, how many they get in there, because we're certainly getting a lot.
Good night.